And now, Dr. Chopra, MD, who's a pain medicine specialist with special interests in complex pain conditions such as EDS, CRPS in adults and children. Dr. Chopra has completed his residency in anesthesia and critical care from Harvard Medical School. And he completed his fellowship in pain medicine also from Harvard Medical School. He is now an assistant professor at Brown Medical School and the director of Multidisciplinary Pain Management Center. He is the recipient of many awards, including the Schwartz Center Compassionate Caregiver Award in 2013. So clearly he's very qualified to give this. So here we go.
Thank you. Thank you, Shira. Thank you. So this is going to be a very, very long talk. So you guys can take breaks. We will take a break, but at an hour. And I think this is going to go on a video. Is that right, Barbara? Okay. And if anyone wants the slides, I'll be happy to email them to you, a copy of the slides. So don't worry about writing down notes and all that. So this is the standard disclosure. I don't have any conflict of interest. No one's paying me. I'm not paying anyone. There'll be a discussion on off-label use of drugs. And this is only for information purposes. Talk to your doctor otherwise. So chronic pain in children. This presentation has been divided up into a bunch of different conditions. And obviously, we're not going to discuss regular pain conditions like, having a headache or something. But this is some of the more difficult ones that haven't been treated well. Chronic pain in children is exactly the same as in adults, except that most healthcare providers know very little about it. And they finally blame it on the parents of the child. So usually an evaluation with me takes about 5 to 6 hours. 5 hours? 5 hours. 5 to 6 hours. And I'm going to squeeze that all into 2 hours. So let's see how that works out. So we'll talk about Ehlers Danlos Syndrome, pain in Ehlers Danlos Syndrome, POTS, mast cell activation syndrome, and complex regional pain syndrome. I'm just curious, how many people here with CRPS? Oh, we have a fair amount. Okay, great. So let's start with complex regional pain syndrome. The reason I chose this first is because it explains a lot about chronic pain in general. So CRPS is a syndrome characterized by continuous pain that is beyond what is expected of the usual course of any trauma or lesion. The pain is far more than one would expect from any type of injury. It is pain to soft touch. It may spread to other parts of the body. And one limb may have a different color or temperature from the other. It's very severe. There's swelling in that area. The area of pain is usually larger than. So if the pain started in the left ankle, it doesn't limit itself just to the left ankle. It eventually spreads to the left leg, and then it may even spread to the right side. They have pain to touch. That's called allodynia. They have dysesthesia, which is creepy, crawly sensations to touch. There are nail growth changes. Nails grow fast. Toenails, fingernails grow faster. They're brittle. They're discolored. Skin changes. Hair growth changes. Hair might be coarser, darker, or it might grow faster, might grow slower. But what it is not is that it's not an amplified pain syndrome. There's been some talk around about calling it as amplified pain syndrome, which makes me really nervous because amplified means that the child amplified it. We, as patients, are amplifying it, but it's not really amplified. Also, it's not in your head. This is a graphic about CRPS in this hand. You can see swelling. There's color change over here. You can see the swelling between the two wrists. This is another one. You can see a skin lesion over here. Swelling. You can see the socks, the marks over here. The swelling, the color discoloration. The toenail fell off. This is 94 degrees. This is 88 degrees. The official definition is a 1 degree difference. I don't usually accept that. At least, in practice, I actually look for at least more than a degree. And most patients with CRPS have an obvious difference. It's way more than 1 degree. There's swelling. You can see the swelling, the color change. She had surgery on this foot. This one, you can see the nails, they're brittle, they're growing, they're distorted, they're breaking up, they're growing a lot faster. So CRPS in children is the same as CRPS in adults. Why shouldn't it be? It's the same. But the good news is that 58% to 93% of cases will resolve with proper treatment. Unfortunately, the relapses are also not that are pretty high. Between 10% to 48% will relapse. Again, it's more common in girls as in adults. So the best way to diagnose CRPS is to get a good history and a good physical examination. There is no test that will diagnose CRPS. There is no test. Oftentimes, I recommend that a repeat test be done, because today might be a good day, you're at the doctor's, the temperature change is not that obvious, or the color change is not that obvious. It's a good idea to take pictures and take them to your doctor and show them, look, this is the color difference. Have both feet together or both hands together to show the difference. But usually a repeat exam is needed. These are all the tests that people look for, imaging tests, x-rays, MRIs, skin biopsies. None of these are useful in diagnosing it, not at all. Except, unless you're thinking of something else and they want to rule that out, then you can have these tests to rule these conditions out. Some of them I think are actually purely unethical, like the EMG. I would not want to have someone do an EMG, stick needles in me and pass electric current if I have CRPS. So what really happens in CRPS and in most chronic pain conditions? What's going on? Why are people, pain is supposed to be a protective reflex. Why is it behaving in this way? Why does it become chronic? So this is my artwork. Watch it. It's going to go into the Smithsonian one day. So that's the brain and the spinal cord. And it's called the central nervous system. That's the master, that's the center where everything happens. Those are the nerves that come out from the spinal cord. What happens is, when you have a trauma, one of these nerves gets inflamed. So say for my left foot, I have an injury in my left foot, and I now develop CRPS there. This nerve over here gets inflamed. It starts sending up signals into the spinal cord, up into my brain. What happens is, the brain then starts sending out signals down. So this nerve is sending up signals up into the spinal cord, into the brain. The brain in turn sends signals down, all the way down here, to help suppress those pain signals and do other things. Eventually, so because in CRPS what happens is there's a constant barrage of pain signals traveling up, and then there's a constant barrage of pain signals traveling down. What happens is that this whole system, the central nervous system, becomes sensitized. And that's what we call as central sensitization. So once it becomes sensitized, then all the other nerves start becoming painful. And this is how it spreads. This is how we recommend that patients not have any trauma, because then this nerve, say for example this patient had CRPS on this nerve, they would start developing CRPS on this nerve. This is called central sensitization. And this explains almost all chronic pains, especially neuropathic pains and CRPS. So the treatment should be based on treating this problem over here at the central nervous system level, not at the nerve level. So, and this is the reason why I don't recommend nerve blocks, because if I block this nerve, how is it going to help this? Now, what I've done is I've graded my treatments into 4 colors: effective, worst trying, use caution, which really means in English is don't even think about it. And then the blue stuff, you can sleep it off. It's just nerdy stuff. So central nervous, this is the official definition for central sensitization. There's an increase in excitability of the neurons. So nerves become more sensitive in the central nervous system, and what happens is they produce abnormal results. So a simple touch becomes more painful. What really happens in the central nervous system is that there are 2 things that happen. One is there's something called the NMDA receptors. Receptors are little keyholes. In our body, we have lots of keyholes. And drugs and chemicals work on these keyholes. When there's a specific key that goes into a keyhole, things happen. And also what happens is the glial cells, these are cells in our nervous system that get activated. This, again, going into the Smithsonian, this is the nerve and these are the glial cells. So the brain and the spinal cord is made up of these nerves and these glial cells. In fact, 70% of the brain and the spinal cord is made up of glial cells. It's only about 30% that you have nerves. For the longest time, we thought that glial cells didn't do anything. What we've now found out is that these glial cells get inflamed. So once there's central sensitization, once I develop CRPS or chronic pain, these glial cells get inflamed. Once they get inflamed, they start releasing chemicals, which are called, they're different kinds of chemicals, but they're grouped together as cytokines. Once these chemicals get released, this nerve, these nerves in the central nervous system get inflamed. So the treatment of CRPS lies in treating the glial cells, not in doing anything to the nerve. We've got to discover drugs, we've got to use drugs that will stop these glial cells from being activated. Anything I do for the nerve is not going to make a difference because the glial cells are still going to cause inflammation. So how do you manage CRPS? As you know, management of CRPS is really difficult, and my theory on this is that you've got to use whatever tools are available. Whatever is available, use it. First thing is to start treatment immediately, even if you suspect CRPS. Must be evaluated by someone who knows CRPS. Treatment should be directed towards restoration of function. So we really don't care about what number the pain is. In fact, most times I don't even ask patients what their number of pain is. It's, are you functional or not? There are people who are functional at 9 or 10 pain, and then there are people who are not functional at 2 or 10 pain. So the main thing is to get them to be functional. Multidisciplinary approach, I put it there because it's in all the books, but honestly it doesn't work. There's no way multidisciplinary approach works. No one talks to anyone at all. Even though we text 100 times a day, we email 1,000,000 times a day, but no one talks to anyone. So this is the key thing. I'm going to repeat this slide again and again. Start low, go slow. This is a key thing in treatment of chronic pain. Again, just to remind you, green is effective. Well, they're basically traffic signals. The first group of drugs I like is free radical scavengers. They're also known as antioxidants. So what are free radicals? So we know that the human body is made up of cells, molecules. Molecules are made up of atoms. And each atom has one proton and one electron. Not one proton, one electron, but an equal number of protons and equal number of electrons. Protons are positive charges, electrons are negative charges. And there's always a balance. There have to be equal number of plus charges and equal number of minus charges. So I'm going to go jump to this. So this is, again, the Smithsonian. So this is an atom, and there's a plus charge and there's a minus charge. When they're balanced, it's a happy molecule. All right? When it loses this negative charge, it becomes very angry, one very unhappy radical. Now, how does it lose this charge? Natural processes in the body, there are oxidative processes going on in the body where you lose an electron, where we lose these electrons by large numbers. So when it's not a happy, it's now called a free radical. And a free radical is going to look for ways to neutralize itself. What it does is it steals from healthy tissue. These free radicals will then steal from healthy tissue. They'll steal electrons to neutralize themselves, which means that they destroy healthy tissue. All right? So I don't think there are any more Smithsonian pictures here. So some of the free radical scavengers are what we call as antioxidants are alpha-lipoic acid, vitamin C, DMSO, N-acetylcysteine, NAC. They're all available over the counter. Let's talk about alpha-lipoic acid. So they've done studies and they've shown that it does work very well in diabetic neuropathy and other polyneuropathies. They haven't done any trials on CRPS. And in fact, in Germany, and actually in Europe, where they look at these kind of drugs, which we call as herbal and over-the-counters, They actually look at this. They have a PDR. Germany has a PDR for these kind of drugs. And it's been approved as a drug of choice for treatment of neuropathic pain. So it helps with autonomic neuropathy, POTS, dysautonomia. The studies were done using IV alpha-lipoic acid. I don't think they do that in the US. It can be taken orally. You can buy it over the counter, 300 milligrams to 600 milligrams a day. Again, start low, go slow. You can always start at 150 milligrams and increase it to 300 milligrams. Vitamin C is a natural antioxidant. There've been studies. There've been 2 studies that have shown that vitamin C can prevent CRPS. They took a bunch of people who had fractures. Half of them, they gave them vitamin C. Other half, they didn't give them vitamin C. Those who didn't get vitamin C had a higher incidence of CRPS. My question is, we haven't studied them in people who already have CRPS, so why not try it? It's 500 milligrams. You can take it. The study was done for 45 days, but I think it's safe enough to be on vitamin C, 500 milligrams every day. DMSO is a topical. Anybody from the veterinary sciences over here? No. So they use this in veterinary sciences a lot, DMSO. It's only for topical use. The studies that they were done on CRPS, actually, they were done in Netherlands. Those are the studies down there. Where they used it, they applied it 5 times a day, and they found significant improvement. So the recommendation was to use it in warm CRPS for a year, and in those who had cold CRPS, they said to try it and see if it would make a difference. You can buy 50% DMSO. When you apply it, wear gloves. Wear gloves with it because it really absorbs into your skin. N-acetylcysteine, this is a really good drug. I really like it. You know how people with CRPS have one cold leg and the other one is warm? It really evens out the temperature between the two. It's one of the drugs I would really like using. You can go to 300 milligrams 3 times a day. I should have changed that slide. 600 milligrams is the normal dose. Again, I like starting low, so I think it's a good idea to start with 300 milligrams a day. These are all green. So low-dose naltrexone, also known as LDN, this is a kind of a really interesting drug that we've been looking at for some time. Naltrexone is an antagonist. It works against opioids. It was initially developed for the treatment of heroin addiction. What we found out, if you use it in a really small dose, it suppresses those glial cells. You remember I showed you those glial cells that got all red hot and were releasing all these chemicals? It suppresses those when taken in a small dose. These are some of the theories. Again, this is nerdy stuff. These are some of the theories on how it works. If you're interested, you can look at it. But what it does is, one of the theories is that it increases endorphin production in the body. And we know endorphin is actually far more powerful than any morphine you can take. So it increases your own endorphin levels. That was one of the theories. It works on something called the OGF, the opioid growth factor, which helps in tissue repair and healing. And then it works on something called the toll-like receptors, which decreases glial cell activation. So the good stuff, the standard dose is 4.5 milligrams. It has to be compounded by a pharmacy. You need a prescription for it. They'll compound it. And I always suggest starting at half that dose. Start taking it in the morning, every day, once a day, and see if it makes a difference. Usually, I recommend that you try it for at least 12 weeks before you decide if it's working or not working. And obviously, avoid any opioids when you're on it. Over the years, we've been using it for about 2 or 3 years now, LDN for the treatment of CRPS. Now we're using it for the treatment of EDS pain also. We're finding pretty good results. I mean, it's not 100%, but we do find pretty good results. Enough that we're encouraged to keep using it. This is a young girl. She was 12 when we started her on LDN, and that's all we did. She has CRPS of this foot. She's got dystonia. This was after a few months of being on LDN. This is a group of drugs called bisphosphonates. They're used for treatment of osteoporosis. these are some of the drugs you can get: flordronate, alendronate, and pamidronate. You know, Fosamax and those stuff, that's what these drugs are. What they did was, they've done some studies to see, you know, one of the things with CRPS is they have bone thinning. And so the idea was to let's give them something for their osteoporosis that they have. And they found out that these patients, their pain was getting better. And so they said, oh, maybe there's something to that. And so they have been using pamidronate IV. They've been using pamidronate IV for some time. And again, like everything else, you're getting mixed results. There's no harm in trying it. Alendronate comes as an oral form also. But I think an IV form is a better way to do it. There's a new drug that it's in development, neridronate. This study was done, it's very similar to alendronate. This study was done in Italy. And frankly, I wasn't very impressed with the study. They said 100% of the patients got better. Now, whenever somebody says that 100% of the patients got better, I get a little worried. Their patient selection was very, very, very strict. And I know because I have 2 patients who failed that study, so wasn't 100%. But anyway, it's something. They are now doing a study in the United States. Hopefully, it'll be a better study, and it might be available. It might be the first drug approved for the treatment of CRPS. So my thing is that it's worth trying it, especially if you have changes, if there's osteopenia or osteoporosis. Why not try it? There's no harm. It's been approved. Ketamine is again a drug that's been around for a very long time. It was initially approved for the treatment for use in anesthesia. Still used in anesthesia. Now, you remember I said when you have central sensitization, there are 2 things that happen. One is the NMDA receptors get activated, and the other was the glial cells that get activated. Well, this is the other one, the NMDA receptors. Ketamine blocks NMDA receptors. Okay. Now, what they've seen is that when people have central sensitization in CRPS, there's a proliferation of NMDA receptors. They like proliferate all over the central nervous system, and they become really activated. So the idea was, why not use a drug that blocks these NMDA receptors? And ketamine is one of the better ones. There are a few others. You know, the cough syrup, Robitussin DM, the DM is supposed to be an NMDA receptor blocker also. But it's not as strong, not as powerful. The thing about ketamine is that if you use it in a small dose, in half the dose, it's a good analgesic. It controls pain better. But the idea behind giving it is that you want to block those NMDA receptors, because these NMDA receptors are now activated and proliferated. The problem with that is that you can't give it orally. It doesn't work orally. That's the problem. You get more side effects when taken orally. So I didn't know what to do with this, so I came up with the idea of using it as a nasal. And it does work as a nasal spray very well, but the problem was that it's acidic, and it causes nasal mucus irritation. So we gave up on that, and then we came up with this idea of using a submucosal or a sublingual drug. I'm going to jump to that. Yeah. So the submucosal is called ketamine sublingual or ketamine troche. You put it under your tongue, or you put it in your cheek, and then you repeat it after an hour, you repeat it after another hour, and eventually after 4 or 5 times, or 4 or 5 hours, you start to notice a little break in your pain. It's a good way. It's not the best way to have it, but it's a good way if you're having a flare-up, like an emergency room type visit. Let's go back to ketamine. So the idea behind giving ketamine is, there's some controversy about it. There are people who are for it, and then there are people who are against it. And there's all sorts of controversy out there. The idea behind ketamine infusions is, IV is the next best way to do it, is that it's not how much is given, but how long do we give it for. Because you want to block those NMDA receptors as long as possible. And the other problem is, how do you minimize trauma while giving it? You remember how I showed you the nerves are getting all inflamed? So we don't want to be sticking needles again and again to get an IV in, and then that causes your CRPS to flare up, and now we're giving you ketamine to reduce it. So that's, again, something to be very aware of. But ketamine infusions are only useful if they're done in conjunction with other therapies, especially physical therapy. That's the only thing. It's not a treatment. It's not a cure by itself. So it's given in sub-anesthetic doses. That means you don't get anesthesia from it, but you just feel kind of sleepy from it. Rough estimates have shown that about 85% of patients respond to it. It improves their daily activities, reduces their medications, and mostly it improves function. Outpatient is done over 10 days. Most centers do it over 10 days. Every day it's done. Some centers will actually admit you and do it for 5 days continuously, day and night. And then outpatient is done as for 10 days. And again, dose is increased every day, slowly, as much as the patient can tolerate it. And then a booster is given. So after the first 10 days, a booster infusion is done after about 2 weeks, and then boosters are done after 4 to 8 weeks for 1 day. It depends, it's customized to each patient, and it depends on each patient how they respond to it. The side effects are usually temporary and short-lived, and they're reversible. Some of them are, some of them are just nausea, these are the common ones, nausea, vomiting, colorful dreams, and sometimes you might get into hallucinations and headaches. There are no long-term side effects that we've seen so far. It's been used, IV ketamine has been used for the treatment of CRPS for a good 10 years. They haven't seen any long-term side effects from it. Oral ketamine, I give it a red. See that? So don't bother. There are too many unpredictable side effects, doesn't work. This is a patient, he had, before this is infusions, we were desperate, we didn't know what to do with him. We started his infusions, and this is what he looks after a year after that. He looks even better now. Muscle spasms, these are a big part of CRPS. Dystonias, tremors, cramps, and some of these muscle relaxants are magnesium, Valium, alprazolam, Xanax, Flexeril, tizanidine, baclofen. None of them work really well. So I put it as a yellow, worth trying it, but nothing to get excited about. It's worth trying it, especially if you're having a bad flare-up, then you can take one of these. It's your choice. Baclofen or diazepam are some really good ones to try, actually. Baclofen oral. There's something called baclofen's pump, the intrathecal pump. They put a spinal pump. This has not been shown to be helpful. Magnesium, this is a great drug. This is one really good chemical. What it does is it down-regulates the NMDA receptors. All this, how I told you they were proliferating, so it tells them to okay, you guys, you've got to calm down. So magnesium helps with that. There have been studies that done with IV magnesium for CRPS. Now, they do a blood test for magnesium, but it's not accurate because most of the magnesium lives in the muscles and bones. But you can try an oral magnesium. Oral magnesium, the one I recommend is called chelated magnesium. This is magnesium combined with a protein, with an amino acid. They combine it together, and the absorption is about 98%. So it's worth trying that. You can buy it over the counter, chelated magnesium. One quick note about buying drugs over the counter, be careful which company you're buying it from. There was a recent incident a few months ago where the Attorney General of New York actually filed a lawsuit against, I believe GNC and a bunch of other major stores where over-the-counter supplements didn't really have what they were supposed to have. 70% of the supplements didn't have what they were supposed to have. So I would really look for US-based companies with good quality control. Sympathetic nerve blocks is a red over there. They do stellate ganglion blocks. They do lumbar sympathetic blocks. There's absolutely no good data to show that they work. In fact, they're very risky. There's no diagnostic or therapeutic value. I've had questions being, that patients have been told that, because your nerve block didn't work, that means you don't have CRPS. That's not true. At best, they're temporary, maybe a day, maybe a few days. But the problem is that they're too risky to do these. So I don't really recommend them. So I did this cool thing over here. So don't even bother doing that. Electrical stimulation. There are all kinds of snake oil remedies out there that zap people with all sorts of electricity, microcurrent, macrocurrent, all kinds of things. Please don't. Because remember how I told you, the problem is with the central nervous system. The glial cells are activated. You have cells that are releasing chemicals that are causing inflammation. If I go and do something to the nerves, it's not going to make a difference. Least of all if I electrocute them. But you can try a TENS unit, which is fine. A TENS unit is not a bad idea. Oh, did that cool thing again. So remember, the problem is the problem is not with the nerve here. The problem is over here at the center, where the nerves are all getting, where all this is getting inflamed and nerves are getting inflamed. So treating this, anything I do to this, even cutting it is not going to make a difference because the problem lies over here. Hyperbaric oxygen, there's no good data on this, not even worth wasting time on it. There's there are like 5 papers written on it, mostly by people who own hyperbaric centers. It's expensive, it's really not useful. Let's talk about the burning question, opioids and narcotics. Does anyone know what are the chances of someone getting addicted to narcotics if they take it for chronic pain? How much? 5%. 2 to 5%. And everybody in the United States is now all up in arms. Oh, you are going to get addicted. I have had 80-year-old women being told that you'll get addicted. I've had people who are dying of chronic pain, severe pain, have they been told you're getting addicted. The chance of someone getting addicted when they take opioids for chronic pain is between 2 to 5%. That's all it is. Anyway, so the problem with opioids and CRPS and central sensitization is that opioids actually make central sensitization worse. That's the problem. You remember how I talked to you about using LDN, low-dose naltrexone? That's an opioid blocker. So what they did was, when they were doing this research, they said, all right, opioids, when they give opioids to these, when they give opioids, the central nervous system gets even more sensitized. What if he did the opposite? What if he went and blocked it? Would that help? And they, sure enough, they went and they blocked it with naltrexone, and they used another drug called naloxone. They found out that they could actually reduce pain. So it's a great option. LDN is safe. It's not addicting. It's none of this. It's not a narcotic. But the problem with taking narcotics is it causes glial cell activation. Especially if you take it continuously for a long time or in a high dose, it causes glial cell activation. But if you're having a flare-up, then it's all right to take it. There's no harm. For short-term uses, it's fine. A week or 2 weeks, a few months even is fine. It's not bad. If it helps you be more functional, if it helps you to get to where you want to get to, if it helps you with physical therapy, exercising, absolutely, it's worth it. There are neuropathic pain medications. I'm not going to dwell on this because if you're here, that means you've tried all these. And frankly, I don't think any of these work. Everybody is happy about writing prescriptions on gabapentins and Lyricas, and now they don't work. I don't write them because by the time they see me, they've already tried this stuff. But I just wanted to, for those of you who haven't tried it, then gabapentin and then there's pregabalin, which are kind of cousins to each other. You can try those. The only problem with gabapentin is it takes much longer to work. But try it for 8 weeks. If in 8 weeks you haven't seen a difference, come off it. Antidepressants, they have some role in helping with sleep and some with pain, especially a group of drugs called amitriptyline and nortriptyline. These two, I think they're marketed as Elovil. It's worth trying them. They do help with sleep also, and some with pain, especially muscle pain, they do help. But antidepressants otherwise, like Prozac and Zoloft, don't work for pain at all. There's one drug, actually, which is not that recognized. It's called Savella. It's been approved for fibromyalgia. In that, the way it works is it increases your norepinephrine level. But the way it works is much better. It makes more sense in controlling pain. So a pain signal travels up. As a pain signal travels up to my brain sends down a signal to dampen the signal, the pain signal. This is what Savella does. It improves the damping signal. Clonidine is a drug that's used for treating blood pressure. You can use it, when used in a small dose or as a patch, it does help with CRPS. You know the allodynia, the pain to touch, it helps with that. It's also a good drug, we'll talk about it later on, it's a good drug to use in patients with Ehlers Danlos Syndrome also. And especially if they have a high sympathetic activity, high thoughts with high tachycardia, it's a good drug to use. Spinal cord stimulators are totally, does anyone have one? Tried one? No, thank God. It's a useless piece of junk. It's an electrode that they insert surgically into the spine, and then it's connected to this little generator, and then you control it with a remote, and it's supposed to work, and they don't know how it works. We still don't know how it works. It's very painful to put it, very expensive. But that's all right. The problem is that, 25 to 50% of patients will develop complications requiring more surgery. Now, this is complications in the spine, that's not a joke. They did a study and they found out that after 3 years, it doesn't work. It stops helping anymore. I mean, it works, but it doesn't help anymore. So why go through this? It's out. Desensitization. So anytime you go, they always like to desensitize. They want to take your arm with CRPS or your leg with CRPS, put it in a bucket of rice and have you twirl it. And I've looked at it. I used to recommend it for years. But I haven't found any logic behind it. So I said, maybe I'm missing something. I looked for literature. I looked for medical stuff on it to explain it to me. There's zero. Nothing. I could find nothing. But everybody recommends it. You should desensitize. And the idea was that, if you get desensitized, then the brain is going to somehow get used to it. But my issue with that is, remember how I talked about central sensitization, where pain signals were traveling up the spinal cord, up into the brain? You're actually sending even more signals up there. You're sensitizing the spinal cord and the brain even more. So why would you want to do that? How is that going to help? We are trying to reduce the central sensitization. We don't want to increase central sensitization. So I certainly don't recommend it. Other treatments, vitamin D, this is a good one to try. Most of us in North America have a low vitamin D level. I don't know about California, but up in the Northeast, it's terrible. People have such low vitamin D levels. There's a clear connection between chronic pain and low vitamin D levels. It's easy to check, and it's easy to treat. Definitely worth trying it. This is a little bit of a snake oil remedy when I first saw it. Has anyone heard of this? Flotation tank? Okay, so I came across this a few months ago, about a year ago, I came across this. It's called a flotation tank. I'll show you, I have a picture. That's the flotation tank. That's my picture there. I look hot. So anyway, it looks more like something like a space-age pod or something. But that's water, and the water is filled with Epsom salt, large quantities of Epsom salt. In fact, so much Epsom salt that you float in it. You don't sink. And then they have no lights or sounds in the room. It basically cuts off all stimulation, external stimulation, sound, light, touch, everything is cut off. And so when I first came across this, I said, one of the things about chronic pain and CRPS, EDS, POTS, one of the common thread that you see through all these is that patients have a very highly activated flight or fight mechanism. We have a flight and fight mechanism. So when I have a tiger chasing me, my muscles are working, my blood is pumping, my pupils are dilated, my heart is beating faster. Most people with CRPS, their heart rate is already very high. Their sympathetic nervous system, their flight or fight mechanism is already very high. POTS is the same story. Dysautonomia, EDS, CRPS, they all have a very high. So I said, why not try this? Believe it or not, it works. This weird pod thing works. And in fact, last night I Googled it. Yeah, there's about 60-minute sessions. I Googled it, and there are a bunch of centers in this area that do it. So, again, I gave it a green. There's no harm in trying it. It's better than sticking a spinal cord stimulator in your spine or doing a nerve block. Graded motor imagery. This is a lot of work that came out from Australia, actually. It's a rehab program. It's broken down into 3 parts. And that's the website. You can look at it, gradedmotorimagery.com. It's in 3 parts. They do it. In the first set, what they do is they do a left-right discrimination. And then they teach you explicit motor imagery, and then they do mirror therapy. Are you doing mirror therapy, Julie? Julie is a physical therapist who does CRPS and EDS in this area. So mirror box therapy, it's pretty tough doing it. It's not easy. But anyway, you can look it up, graded motor imagery. Some of it there's actually an app for it also. But remember again, start low, go slow. Now when I say start low, go slow, I really mean very, very, very slow. Like ridiculously slow, ridiculously low. That's how you have to do it. Because if you exceed anything more than that, it's going to put you back by months. So progress really slowly. Avoid needle stick trauma. This is a huge, big deal. One of the things about CRPS is they have poor veins to start with. Okay, I don't know if it's because of the condition. Otherwise, make sure that you're getting a needle stick. If you're getting a blood draw or a test, everybody's on the same page, all your doctors. You don't want one doctor ordering one test and then a week later somebody else ordering another test. Get them all together. Use the best phlebotomist you can get hold of. Drink plenty of water before you go so your veins are pumped up. And then, of course, if you have POTS and if you're getting IV fluids, then it's a good idea to get a chest port. Or if you're getting ketamine infusions on a regular basis, get a chest port. A PICC line or a midline is not a good option. So this is something that I've just started looking at this. And, the official definition of CRPS is we don't know. There's no other explanation for it. That's one of the key things about CRPS. But I'm beginning to start looking, I start thinking, we're looking at patients with autoimmune dysfunction. We're looking at patients with bone issues, like EDS, who are developing CRPS. We're seeing patients with nerve damage and nerve entrapment who are developing CRPS. So look for a cause. There might be a cause. Is there a nerve damage? Is there a nerve entrapment? We'll talk about nerve entrapments. Do you have EDS? Is that what's doing it? Or is there an autoimmune dysfunction that's doing it? We don't know a lot about autoimmune dysfunctions. We don't know all the antibodies that are causing a lot of these diseases, but it could be one of these. This is a very sensitive point with me. They're often labeled as having a behavioral disorder, conversion disorder, and of course parents are labeled as having Munchausen by proxy. It's really important that parents pay very close attention to their children's complaints. And as Barbara explained a little earlier, don't believe everything that they say. The doctors say, understand, you know your child best. You listen to the child and believe in them. So I looked at we physicians are great at labeling people with conversion disorder at the drop of a hat. Somebody walks into the room, looks at the child for 10 minutes, and goes back and writes down conversion disorder in their chart. Conversion disorder, the incidence is less than 1%. Munchausen by proxy is 0.5 out of 100,000 patients. The incidence of Ehlers Danlos Syndrome is 1 to 10%. So EDS is far more common than conversion disorder. It's far more common than Munchausen by proxy. CRPS is far more common. There are 20,000 new cases every year in the US. So why do we jump to the rare conditions like conversion disorder or Munchausen by proxy? The reason is that psychiatrists are not trained to treat pain. They don't understand pain. Pain physicians are not trained in psychiatry. So no one's really talking to each other. So what they do is it's easier to just blame it on the patient and say you have conversion disorder or Munchausen by proxy. If there's anyone who gets, if you even sense that they're going in that direction, please don't go back there. So to diagnose a child with conversion disorder or Munchausen by proxy without a dedicated multidisciplinary team approach and without concrete evidence, you have to have concrete evidence, is extremely harmful to the patient. Makes me angry. So I gave it, in fact, it's got a new one, angry. I've got an angry bird also. So let's talk about Ehlers Danlos Syndrome. So there's been, we did talk about Ehlers Danlos Syndrome a little earlier. Chronic patients present with chronic body-wide pain, all my joints hurt, headaches, dizziness, racing heartbeats, palpitations, belly pain, pelvic pain, brain fog. These are some of the presentations they have. I wasn't sure if there were people, because it was a chronic pain talk, so I put in some questions that I usually ask patients before they come in. But everybody over here, does anyone have a doubt about having EDS? Or you do. So the questions are, do you amuse your friends by doing all kinds of party tricks? Does your kneecap slide around? Have you ever been told that you're double jointed? Severe growing pains? If you're answering yes to some of these questions, then it's possible. Are you klutzy? Do you bump into furniture, trip over easily? Drop things often, bruise easily, unexplained bruises, stretch marks. So I'm going to skip this because we've already talked about this. But this is the thing I want to tell you about Ehlers Danlos Syndrome. It's not a disease. Okay? It's just another form of the human body. All right? So there are tall people, and then there are short people, and then there are dark-skinned colored people and white people. Then there are hypermobile people and not so hypermobile. All of these people, so tall people have different medical conditions from short people. Dark-skinned people have different medical conditions as compared to white people. So I don't want you to go through life thinking, oh, I've got this horrible disease that cannot be cured. It's just a form of the human body. That's all it is. How do you diagnose it? It's diagnosed basically on taking a good history and understanding patients' issues, doing a physical examination. Genetic testing, we've gone through that. The one thing we do is, of course, the Beighton score. So the scoring, and you can do that yourself. The Beighton scoring is 9 steps, 9 of them. So I always tell people it takes 9 seconds to diagnose someone. Do the Beighton score. That's all it takes, which I think should be a screening test in most schools. So one of them is to see if you can push your thumb down and touch your forearm on each side. So you add one on this side, one on this side. The second one is if you can pull up the pinky, put your hand, flat of your hand on a table, and you pull up the pinky. And if you can go more than 90 degrees, that's 1 on each side, so that's 4. Bring up your arm like this, and if you can see, there she is, hyperextending. So there you go. Hey, Sheila, you have EDS. Oh, no. Oh, no. So that's the easiest way to see that. The way to look at it is, see this convexity, and then there's a concavity. So you can see the elbow kind of hides under, and that's how you look at it. Knees. The best way to look at knees is to stand like this, and sort of lean forward at the hip, and that's when the knee kind of sticks back. Again, it's 1 on 1 for each side, so that's a total of 8. And the 9th one is being able to touch the floor with the flat of your hands. I don't usually go up till there. If they have crossed 5 or 6, I'll stop, because this is one I don't really like doing this test. And again, as we talked about it earlier, is if you don't have it now, did you have it previously? So there is no cutoff. And just because someone has, say, 8 out of 9, that doesn't mean that it's worse than somebody who has it 4 out of 9. It doesn't mean that. It's just a scale. That's all it is. So don't be alarmed. Oh, I'm 9 out of 9, and so I'm as worse as it can be. It's not like that. But there are other signs to look for. This is not just the only thing to look for. Do you sit like this? It's called the W pattern. If you do, then don't. No, there have been pediatricians who actually said it's all right to sit like that. So this is a no-no. Because I can't even tell you how many ligaments are being stretched over here. The problem is kids like to sit like that. It makes them feel comfortable. This is the other sign called the Namaste sign. You do it on the back. You can put 4 fingers in your mouth. What do you think? You have it? So the normal is 3 fingers. Yeah, so normal is 3 fingers. Amy, that's 6 fingers. So the normal is 3 fingers, okay? And if you can put 4, then of course it's positive. But then again, you have to take into factor that most people have TM joint issues and they're not able to open their mouth as wide. So it's not a conclusive diagnosis, but it adds to the jigsaw puzzle. Scarring, it's very thin in the middle. We talked about that. You can see the scar in the middle is paper thin. It's classical. These patients have this kind of wide scar. In fact, I've seen Ehlers Danlos patients get scars from mosquito bites. Flat foot, the arch collapses. They actually have a high arch when you lift up the foot, but the minute you place it down, it's flat. That's because all the ligaments stretch out and the foot and the arch collapses. Don't ever do this. I think this was a girl she was trying to show me, and don't ever do this. But these are signs. Now, one of the things is that they do hold a pen like that, and they try to use as many fingers as they can, as much surface area they can, and they hold it very tight. They really hold it really very tight. And we'll talk about it. Why is it? They have what is called poor joint position sense or poor proprioception. This, you can't see it on the screen, but you can see blue sclera, this blueness over here. This is blue over here. You can see the blueness. That's because the eyeball is made up of this white connective tissue. We normally don't see that. We see it as white. But in patients with EDS, it's thin, so you can see the black retina inside, which looks bluish in color. Other signs, blurry vision, history of severe growing pains, fatigue. Fatigue is a big deal in kids. In fact, they may not complain as much about pain as much as they complain about fatigue. Feet turn dark in color when standing. They have difficulty maintaining body temperature. They're cold, they're hot, they can't get warm enough. They're very, very clumsy. They'll trip over everything, bump into things. And there's an explanation for this. It's because they have poor joint sense. And I'll show you why. So the thing with connective tissue disorders and EDS is that everything in the human body, so the human body is made up of bones, muscles, skins, organs, and they're all connected to each other by what is called as connective tissue. So it connects everything, so it's called connective tissue. The connective tissue is, normally, connective tissue in me is like rope. It's flexible, but you can't stretch it. You can't break it. It's strong, but it's not stretchable. In EDS, it is stretchable. And like anything that is stretchable, if you stretch it too much, it'll stay stretched. And if you stretch it way beyond, then it'll break. And once it breaks, it doesn't heal up as well. You saw the scar. Now that's on the surface that we see. What's happening inside? It's the same thing. You have surgery, it heals up like that scar over there, paper thin. That's why surgical outcomes in EDS are not that good. If they injure themselves, if they hurt themselves, they break a ligament inside, it doesn't heal up as well because they have that same paper thin scar. So, so the types of pain in EDS is, there are different types like everywhere else. Mechanical pain, also known as nociceptive pain, inflammatory pain, where there's inflammation, nerve pain, muscle pain, and headaches. So what really happens, why do patients with who sublux their joints have pain. The reason is it's not the bones themselves that cause pain. So if my shoulder dislocates, it's not the joint, it's not the movement of the bones. It's the ligament being stretched. It's the muscles that are being stretched. So what happens is if my shoulder dislocates, then the muscles, the rotator cuff group of muscles that hold it in place, they go into a spasm. And that's what causes the pain. It's the ligament that holds, the capsule that holds the joint together, that gets overstretched. When that gets overstretched, that's what causes pain. It's not the bone themselves that cause pain. They have loose, unstable joints, they dislocate or subluxate. So this explains very neatly what subluxation. Subluxation is when they're overstretched. Dislocation is when that capsule breaks. This is the difference. So, like I said, if you stretch it too much, it'll come into subluxation. If you stretch it way beyond, then it'll start to dislocate. The problem is that when this heals up, it's not going to heal up as strong as before. It'll still be a weakness. This is a very important concept. If there's one thing you want to learn about EDS today, it's this concept, joint position sense. It's called proprioception. That's the fancy medical word for it. But what it really means is joint sense. It's the body's ability to sense movement of the joints and their position. So when I walk, I'm not looking at my feet. I can, in fact, walk with my eyes closed. But I don't fall over, I don't tip over, I don't change direction is because there are sensors in my joints that send messages to my brain telling me exactly how high my knee is and how high is my right knee and so on. And that's how I balance myself. If you have wear and tear of these joints, then we lose this joint sense. There are sensors in the joints, in the muscles, in the ligaments, in the tendons that keep sending messages to my brain. In the extremes of age, so as a baby, you don't have proprioception because it's not yet developed. That's why kids fall a lot. And as you grow older, at your old age, you start to lose it because there's more wear and tear of the joints. In athletes, they lose a lot of their joint sense. That's why they always wear these things to protect their joints. And in EDS, they lose that. And that's the reason why patients with EDS are kludgy. So this is a graphic. So what's happening is that there are signals being sent up from those legs up into the brain, and then the brain decides and sends out signals to the rest of the body to balance yourself. So this is exactly what I just explained was the repetitive wear and tear causes you to lose joint sense. And that's the protection we lose. What happens is so having joint sense is important is because one, it helps me balance, of course, so I don't fall as much. But it also helps me from overstretching my ligaments. If I'm walking and if my knee subluxes or if my knee hyperextends, I'm going to damage some ligaments. I can't do that because my sensors are telling me to stop. Your sensors with EDS, it doesn't tell you that. You hyperextend your knee every time you walk. So you can see that toddlers have poor proprioception, and that's the reason why they fall such a lot. So what's a good exercise? Juggling is a good exercise. Balance board or wobble board is a good exercise. A wobble board, a wobble board is a plank with half a ball at the bottom. Stork standing, you stand on one leg. So you stand on one leg with your eyes open, then you can stand with your eyes closed. You can hold on to something. Sitting on an exercise ball. Exercising in water. Why is exercising in water so helpful for patients with EDS? Because remember, I told you, you lose joint sense, right? So the brain uses whatever messages it can get. So if I'm in water, it's the water touching my skin. And that is what the brain uses to figure out where the knees are, where the joints are. That's why water therapy or aquatherapy is helpful in these patients. It's because there's contact with the water that helps the brain understand their exact joint position. Also, it makes you buoyant, so you're not really putting any impact on your joints. That's another reason. Now, in exercise, walking in water is great, treading water is great, but no swimming. Because in swimming, you can damage your shoulder joints. This is a pictorial about something like stork standing. So things to remember is do not overstretch any joints or ligaments when you're exercising. Modify exercises for regaining joint position sense. Avoid contact sports like ballet, basketball, rollerblading, any of those. This is important because once the damage is done, once the ligaments are overstretched or once they are broken, then it's no going back. It's really difficult to go back. And this is the reason why I say that we should be doing Beighton scores training in schools, is to figure out who should be in contact sports, who should be, because EDSs make great ballet dancers. They're so flexible. They make great ballet dancers. They're tall, they're slim, they're the perfect people for that. And of course they do well, so they feel encouraged about it. Did you do ballet, Amy? You look like you did. So running in water, exercising in water, walking in water is great. You can swim, but on a condition. The condition is that you can hold on to a kickboard, okay, and wear a snorkel. So you're not turning your head again and again, and you keep your arms straight, and then you can exercise your legs. This is a wobble board. This is a great way to exercise, stand-up paddle board. It gives you a great sense of proprioception. I'm the guy in the front. Hey, what? I can't be the guy in the front? I'm hurt. That was hurtful. All right, whatever. Compression garments, these are great. Like the same principle I explained to you about getting into water and having something contacting your skin. You can use this on land, compression garments. You have this contacting your skin around the knee, and it protects it. And these are designed for athletes to protect their joints. This is my particular favorite, is because it not only helps with joint sense, it also helps with POTS. If it's compression, if it has enough compression, it'll help with POTS also. This is something that I really like a lot, called kinesiotaping or neuromuscular taping. It should be done by somebody who really knows how to do it and really understands EDS and the use of kinesiotaping, because the standard kinesiotaping techniques may not apply in EDS. So there's a little bit of a learning curve. So what is kinesiotape? It's not just simple duct tape that holds you together. It mimics the superficial layer of the skin. In fact, it's so well designed that after 10 minutes, you don't even know you have tape on you. It's designed to stretch, so they can actually, the physical therapist can stretch the tape as they put it on, depending on what's needed to be done. It's porous, so it dries easily, so you can take a shower with it. The adhesive on that, see that waveform is called fingerprint technology. So it's like fingerprint. So it's like, it helps with repositioning the muscles. And you can actually, I think most kinesiotapes, you can keep them on for 4 or 5 days. So the tape stimulates the sensors of the skin, which helps with proprioception. It helps reduce swelling. These are the uses. It reduces pain, it improves movement patterns, it relaxes the muscles, stabilizes the joints, supports weak joints, and reduces swelling. It's a win-win. How much does it cost to do kinesiotaping a day? $1.50. I calculated that. So helpful for neck pain, upper back pain, lower back pain, SI joints, muscles, wrists, shoulders, knees, ankles, and feet. Pretty much most joints that get affected. Is there a downside to using it? Not much, other than if you have a reaction to the adhesive. It's actually latex-free, but you can. And there are things that patients have told me. Like one patient told me that if you put Epsom salt on it and let it dry and then put the tape on, it helps. One patient told me that they spray Flonase. Flonase is a steroid, and they spray Flonase, and then they put the tape on. So these are some of the techniques. It might be worth trying different companies. If you're reacting to it, try a different company. It might be just the chemical and the adhesive. This is too busy to read it to you, but this was a study that came out in 2015. In February of 2015, where they went and taped the knee and the back in patients with EDS for stabilization. And they, of course, showed there were great results. And I have been trying it on some of my patients, and we are seeing some good results with it. So this will be, in your slides. The details are there and how to do it. Works pretty well, I should say. So kinesiotaping both knees and the back at the same time helped patients with EDS stabilize themselves. Again, start low, go slow. Let's talk about, now I'm going to go through each body part, headaches and neck pain. So there are two kinds of headaches. There are headaches that come from outside the head, and then there are headaches that come from inside. The inside ones are called migraines. And migraines are a whole different animal, and they have a whole different set of drugs that work on them. Often patients have both. So that's coming from inside the head, and that's coming from muscles outside the head. I put 11 of them, but there are actually 22 reasons why patients with EDS can have headaches. I took out the more rare ones. Chiari malformation. Cervicogenic headaches are also, that is the muscles in the head getting tight. TM joint dysfunction, blurry vision, POTS. POTS is a big reason to have headaches. Tethered cord syndrome, trigeminal neuralgia. There's a nerve in the head that gets inflamed. Spontaneous cerebrospinal fluid leak. This is something that only very few neurologists like to tread on. CSF is, so the brain and the spinal cord is in a bag, and this bag is filled of fluid, and so the brain and the spinal cord float in it. And if there's a leak in the bag, you'll get a headache. Most times it's done after doing a lumbar puncture or something like that. But in some of these patients, you can't find the leak. They have spontaneous CSF leaks. Instability of the neck, the craniocervical instability, atlantoaxial hypermobility, which is the head resting on the neck, joints in the neck that hurt, occipital neuralgia, nerves in the back of the head that get inflamed, and then sinusitis. Let's touch on TMJ pain. So that's the temporomandibular joint, this little thing over here. It's a really unstable joint. It slides. It's a gliding joint. And these are the muscles for chewing. These are the muscles for chewing. This is the masseter muscle. That's the temporalis muscle. What happens is that people with TM joint dysfunction, and this is EDS and non-EDS, they tend to grind, they tend to clench their teeth. We all try to do that. These muscles get strained. And then when they get into a spasm, then they start to hurt, which presents as headaches. And then eventually will lead to neck issues. There's clicking noises, clenching and grinding, pain with chewing, jaw locking up. It's very common. I think it's more than 70%. Treatment is to avoid excessive mouth opening, caution with yawning. You don't want to dislocate it or sublux it again and again. If you see an orthodontist, be careful. You don't want to go to anybody. You want to go to somebody who actually specializes in TM joint work. Because number one, it's pretty expensive. Number two, it's not that simple. Somebody has to really study the movement of the jaw and all that stuff. What's wrong, and then they fix it. Rare cases, they do surgery, but most often they'll give you some kind of they call it oral appliance, which you put into your mouth during the day or during the night. Don't use over-the-counter mouth guards. Number one, mouth guards just protect your teeth. They don't prevent TM joint. Instead of grinding your teeth, you're grinding plastic. The third thing is that when you have an ill-fitting mouth guard, you tend to clench even more. Neck pain. The most common cause of neck pain in EDS is actually posture, believe it or not. Correcting your posture now is not a good idea. That doesn't help. So it's called a chin poking forward position, okay? See, this is what happens. You poke your chin forward, it puts strain on your neck, which strains your back, and it causes headaches. So as a demonstration, I'll show you, it's this kind of a position. We all have this position. Most of us do. And the way to fix it is to put a finger on your chin and push it back. That's easy. The hard part is to remember to do it. So before you start looking at MRIs and seeing surgeons and all that stuff, fix this first. And you'll be surprised how much it makes a difference. In fact, it helps almost right away. That's the kind of pain distribution patients with TM joint have. Now, why would somebody stick their chin out? Why would somebody do that? If they have POTS, they have blurry vision. So they're trying to strain to look into their computers. They strain forward to look into whatever they're reading or doing. EDS causes it. Chiari malformation causes blurry vision. So maybe we need to fix that first. Maybe we need to figure out the blurry vision first. Laptops are a no-no. It's a bad idea to use laptops in EDS. Go to a desktop. You need a big monitor. You need to be sitting at a chair with your posture corrected, chin sticking back. Your ears should be in line with the shoulders, like that. Brain fog. Almost everybody with POTS has brain fog. Mast cell activation syndrome, they have brain fog. And they're trying to figure out, and they're blurry vision, and then they have the brain fog. So the posture goes down the drain. So that's... Do you know how to do that? I have a really cool solution. You take a Post-it note and you stick it on the monitor in front of you. But don't write anything on this Post-it note. Leave it blank. Every time you look at the Post-it note, you're going to wonder why it's there. And then you remember, oh, I need to push my chin back. If you write something on it, you're going to ignore it. It's like a painting on the wall. And of course, manage POTS. Use large monitor when you're sitting there. This is a taping for neck pain and headaches. I don't know if this applies to you or not, but what I'm trying to say is that you can use kinesiotaping for a lot of these issues. It doesn't have to be something really fancy, like getting surgery done. Chiari malformation. So these are the symptoms of Chiari malformation: neck pain, balance problems. Now, if you read them, you'll see that there's a common thread in all of these conditions. Balance problems. Is it proprioception or is it Chiari? Muscle weakness, paresthesias, or tingling and numbness in the hands and feet. Dizziness. Is that POTS? Vision problems, difficulty swallowing, ringing or buzzing in the ears, hearing loss, nausea, vomiting, and this is a big one, headaches made worse by coughing or straining. That can happen in migraines also. It doesn't have to be Chiari. This is what happens in Chiari. So this is the normal brain. There's a hole at the bottom of the skull called the foramen magnum. When the brain starts to stick through the hole, it's called Chiari malformation. Depending on how much the brain sticks out, you grade it 1, 2, 3, 4. There's a higher incidence of Chiari in EDS. One of the reasons is that we're not sure why, but the brain, the skull is a brain weighs, the head weighs about 25 pounds, and it's really delicately balanced in the neck, on the cervical spine. The analogy to that is a bowling ball being balanced on a pin. That's how complicated this is. This is how complex it is. And it is held there by muscles, ligaments. And guess what? These muscles and ligaments are stretchable. So is it possible that this 25-pound head, when I stand up, it settles down in my neck. The ligaments get loose and everything sits down and drops down. And so most MRIs that are done for Chiari malformation are done in the supine position. That's when your head is very well rested. It's not pushing down on the ligaments. And that's why I always insist on getting an MRI in the standing position or the upright position. They do look at these angles, really fancy angles called clivus axis angle, clivus atlas angle, and the atlas axis angle. There's a reduction in these angles. These are objective things they can measure, and patients with EDS might need fusion. For treatment of Chiari malformation, they might need correction of these angles with a fusion. Shoulders and back, upper back. So the shoulder, the problem with the shoulder joint is it's one of the weakest joints in the body. The reason being because we need more mobility there, and so we don't have as many muscles. It's, like I said, it's not much pain from the dislocation. It's more from the muscle that's causing this pain over there. Muscle pain is very intense pain. The problem with shoulder is it's an optional joint. So if my right shoulder hurts, I do everything with my left, which makes this shoulder joint freeze up. So it's really important to keep using the same joint again and again. Please do not voluntarily dislocate the should be joint. So that's what kids, please don't, oh yeah, I can take out my shoulder. No, I don't want to see it. Postural awareness and correction is important, sitting on a balanced ball, holding your back against the wall to correct the posture, balanced board. So core strengthening helps with the upper back pain. When you talk to your physical therapist for strengthening your shoulder muscles, these are the three muscles that are usually affected. The pectoralis, this is the pec muscle, the anterior deltoid, which is this muscle over here, and the infraspinatus is the muscle in the back over the scapula. These are usually the three muscles that are affected. This is a great, so this is a compression garment that helps with stabilizing the shoulders. Remember how I said contact with something helps get you your joint sense back, and that's what it helps with. And then you have the kinesio tape that can be done. These are two companies that make compression garments, Tommy Copper and Zensa. One of the things to try, if you're not getting enough benefit from it, you've got one and it's not helping, try a size smaller so you get a little bit more compression. Exercising in chronic pain. Do not do too many exercises at once. Do one or two at a time and keep them really simple, but be very consistent. That's the important thing. Physical therapists are teachers. They teach you how to do those exercises properly. They guide you. But it's really up to us to do it every day. You have to be very consistent with them. We talked about this. Now, this concept of no pain, no gain is nonsense. Okay, it doesn't apply in medicine. I don't know who came up with it. I believe it must have been something with the Marines that came up with it. You know, isn't that, they have a saying actually, I think, fear is pain going away or leaving the body, or something like that. But anyway, no pain, no gain, it doesn't apply to the human body. It's not, you have to exercise to the limit of your pain. If you exercise to the limit of your pain, say you exercise to 6 or 10 of your pain, the pain is still going to keep continuing to rise to 8 or 10, but then it'll drop back to 6. Don't push yourself on this. There is it again. It's important to be consistent and exercise up to the limit. Progress very slowly. Okay, it takes a long time, but you'll see results at the end. Physical therapist, please select your physical therapist very carefully. Don't go to someone, oh, I know EDS. Yeah, you do know EDS, but do you know how to do it actually? That's important. They really must have treated EDS in the past, or at least are prepared to learn it or prepared to understand it. We just had a bad experience with a physical therapist who, you know, oh yeah, I know EDS, and then we had really bad results from it. So not everyone knows how to treat EDS, and I don't blame them because they're not taught this, but they should be prepared to learn it. Okay, I sound like my mother. Posture is important. Chin poking forward position, correct that. So women with EDS, bras, it's okay. Now, it's not just people with, in EDS, we're talking about EDS, it's not people with just big breasts, it's people with breasts. What happens is the ligaments are loose in the back, and now you have a breast in the front that pull you forward, the muscles in the back are pulling you back, and you lose your posture. And it doesn't have to be big and heavy breasts. Even light breasts can do that. The recommendation is to try a sports bra, especially with a racer back, wide straps. There should be wide straps, front closure because you don't want to be hyperextending your joints to be closing the strap in the back. Proper fitting. It is surprising that most women they have their bra sizes incorrectly. You can go to any one of those department stores that sell this, and there'll be someone who knows about fitting them. Get it sized properly. And then Very severe conditions, of course, the reduction mammoplasty, but that's a whole different story. Thoracic outlet syndrome. Thoracic outlet syndrome is actually more common than most people think it is. Patients present with this kind of pain, neck pain going into their arm. It's a common thing. You go to a physician with this kind of pain. They look at your MRI. Oh, you've got a disc herniation. Let's do some surgery there. What really happens is that the first rib is a flat rib. So this is my first rib right here. And over this first rib travels my collarbone. And there's a gap between the collarbone and my first rib. Okay, this gap closes down in EDS because this rib is held by muscles. There are muscles on top that pull it up. And then the collarbone is right over it. And so this gap closes down. The problem with that gap closing down is that there are nerves that travel through that gap. So this is the first rib. And this is the collarbone. And these are the muscles that connect to the ribs in front. So this is called the scalenus muscle. This muscle can go into a spasm, trying to hold up the first rib. The collarbone, the clavicle can get dislocated or sublux or this joint over here, which can then go down. When it does that, it presses on these nerves and blood vessels traveling down. This is another muscle that can go into a spasm that pulls it forward. And these patients present with neck pain and arm pain going down their arm. This is a nerve entrapment. There are some tests they can do. There's no physicians who know thoracic outlet syndrome. Physical therapists know thoracic outlet syndrome very, very well. They can test you for it. The treatment is to start with physical therapy because you want to loosen up those muscles there. You can try trigger point injections or dry needling with physical therapy, kinesiotaping it, and then, of course, if it's not working, then surgical correction. Again, surgical correction, think 5 times before you go for surgical correction. But if it's intractable pain, then of course we'll have to do that. This is a taping for thoracic outlet syndrome. Wrists and fingers. So muscles of the hand, these are small muscles. There are hundreds of muscles in the hand and in the wrist, and these are really small muscles, which means they have no reserve. These muscles get stressed because there are wrist bones that get subluxed all the time. There are wrist bones that get dislocated all the time. So the muscles are trying to keep them back in place. Finger joints, they get dislocated. The muscles try to hold them back in place, and they get tired easily. They hurt a lot. You remember that pen I showed you? So what happens in this case is that when we hold a pen, my brain knows exactly how tight to hold it. You don't want to hold it too tight. You don't want to hold it too loose. Okay? And the way the brain knows the way to hold the pen is there's joint sense in my thumbs and my fingers that tell my brain exactly how tight I'm holding the pen. In EDS, that doesn't happen. They don't get that sense. Their brain doesn't get that sense. So they overcompensate by holding the pen too tight. And when they hold that pen too tight, they wear out their joints. Their muscles get fatigued easily. So the treatment for that is a fingerless compression glove, or the best one is to use a foam padding. You can get this actually online. Amazon has them. It's a dense foam padding. You can stick your pen in it or pencil in it, and it helps a lot with that. Or you can use fingerless gloves that can help with this. Using a thick pen doesn't help. It has to be foam padding. Or you can make it yourself. You can use foam tape and wrap it around a pen. For those who have joint subluxations, you can use a splint. This is a company called Silver Splints, I think they're called. Silver Splints, they make this fancy jewelry-looking splints. The one thing about splints is that they stabilize the joint. They do not cross the wrist crease. Splints and braces in general, let's talk about splints and braces in general. Braces and splints are supposed to bring the joint, maintain the joint in a neutral position. They're not supposed to stop you from using the joint. They're meant to stabilize the joint in a neutral position. They avoid hyperextension of the joint. They help with joint position awareness, proprioception. And then once you've gotten the hang of using it, then start backing off and using it slowly. Alternatively, you can try kinesiotaping it. Now I'm going to jump straight to the feet and ankles. The reason being that the lower half of the body, a lot of this pain is, the problem starts in the feet and the ankles. Pay attention to feet and ankles. Okay? If the feet and ankles are unstable, they make the knees even more unstable, which then makes hips unstable, which then throws the pelvis off, causing sacroiliac joint pain or lumbar pain. So anytime I see a patient, EDS or non-EDS, if they come in with back pain, the first thing I look at is I look at their feet and figure out, like, okay, is there something going on with their feet or knees? And like I showed you, most patients with EDS, I think almost all patients with EDS have flat feet. And they have hypermobile ankles. They have hypermobile knees. They hyperextend their knees, which really makes them very unstable. So this is a graphic. If you have an unstable knee, ankle or a foot, that throws your knee off, which then throws your hip off, which then strains these muscles, causes back pain, and goes all the way up there. So for flat feet, what do you do? Barefoot walking where it is safe and comfortable. That really helps with conditioning muscles. You can do this exercise rising up on your tiptoes and then coming down slowly. So rise slowly and come down slowly. Feet, shoes. I hate to say this, but you have to wear sneakers. You have to wear shoes with laces. The foot has to be held together. We can't have ankles slipping out. It has to be held together. So anything with laces is important here. Cushioned midsole, good strong heel counter. Fastening should be on the midsole. Sneakers are the only way to go. No heels, no, what are they called? Flats, none of that, sorry. Shoe inserts, orthotics, you really need to have orthotics. There's this company that's a really little company that makes something called WalkFit. I think $20, you can buy it in Amazon or Target. Start using these really slowly. Introduce them very slowly. And that goes with all braces, splints, orthotics. Introduce them slowly, 1 hour a day. Go on to then 2 hours a day and slowly progress from there. You have to give your joints time to adjust. I'm not sure how well this will work because it'll probably come off. I'm not sure how well that works. Knees. So as we move up, knees, So the kneecap, which is the patella, is held together by a very fine balance of muscles. And any imbalance of this kneecap, so most of EDSers have kneecaps that slide in and out. And that causes this kind of pain. Because the kneecap is kept in position by these muscles over here. And so any hypermobility of the patella, the kneecap, causes these muscles to hurt. So hyperextension, there's hyperextension of the knees. The hypermobile patella makes it unstable. It strains the ligaments inside the knee. It's difficult to do it, but when you stand, break your knee a little bit. I can show you through my pants, but when you stand, just break your knee a little bit, slightly. You can't do it while walking, but be aware when you're walking. That's the one thing. Be aware that you're not hyperextending it. You can wear compression knee sleeves or tights. The best thing is if you also have POTS, the best thing is to wear something that has compression on it, like Spanx. If not, then you can wear, what are they called, yoga pants. Anything that clings to your skin. That's hyperextension of the knee. That's the knee brace I showed you, the knee sleeve I showed you. this is a great way to go, because if this is tight enough, it can help with the POTS also, and EDS. This is the taping we talked about. The PTF joint, no one knows about this, but it's a very commonly missed cause of leg pain. The PTF joint is a joint over here on the side of the knee, right? On the outside of the knee, if you put your hand, you'll feel a little bony knuckle. It's on the side over here. It's the joint between the fibula and the tibia. This joint. And this is the fibula, this is the tibia, and that's the knee joint there. And what happens is that this joint starts to sublux because it's one of the weight-bearing joints. And this bone goes down there and it makes another joint at the ankle. So when you're involved in athletic sports, what happens is this bone gets pushed up and down and eventually gets pushed out. And this is a subluxing joint it's called the PTF, proximal tibiofibular joint. Most knee surgeons are not interested in this joint. In fact, the last paper I found was written in the 1960s. You know why? Because in the 1960s, there were no MRIs. So that's when orthopedic surgeons actually put their hands on patients' knees and examined them. Ever since the MRIs came out, they've stopped touching their patients. And this is a very commonly missed reason for pain. Where is this pain? This is... Oh, really? I forgot to put that picture. The pain is on the side of the knee, of course, where the joint is, but it also goes up here because there's a band called the IT band, and it connects to that joint. So it's this IT. So whenever they talk about IT band pain, which almost all of us have it, you got to look at the PTF joint. And then the pain goes down their leg because there's a nerve that lives over here, right here. It's called the peroneal nerve. And when this joint subluxes out, it pushes on that nerve. And when it pushes on that nerve delivers down the side of the leg. And oftentimes, patients will have, if that nerve is affected, you have foot drop. And you may not have an obvious foot drop. What will happen is, as you're walking more and more, you'll find that your foot gets caught in the carpet. It gets caught like that when you're tired, because that nerve is now so inflamed that it's not functioning anymore. So if you have that going on, look for this joint. Oh, the way to diagnose it is very easy. If you press on that joint, it'll hurt. The other one is to do what is called a squatting. If you squat, that joint should hurt. They may have foot drop, pain on the side of the thigh, which is the IT band. Do you want to take a break? Huh? No. No. You want me to go faster? All right, prevention. All right, I'll go over the not so important part faster. How's that? So prevention is the key over here. You don't want to overstretch your ligaments. You don't want to break them. So do not stand on one hip or sway at the hips. Do not stand on the outside of your feet. Do not sleep on your stomach. Don't do that, of course. Don't do that also. That's again straining a lot of the ligaments. Don't carry a heavy bag hanging from one shoulder. Have a backpack if you have to. But better than backpack is to have bags with wheels on them. Use a shopping trolley or use a bag with wheels. Keep your handbags light. There's no need to take the microwave to work. Muscle pain. Muscle pain is actually, believe it or not, is really very painful. When muscles go into a spasm, they really hurt a lot more than any other pain. Those can be treated. Firstly is to treat the joint that's causing the muscles to go into a spasm. You can try dry needling. A lot of physical therapists can do that. Trigger point injections can be done. Kinesio taping. Stretching is to be done very, very gently. Trigger points are little muscle knots that develop in the muscle, and they cause pain in a different area. So for example, this is pain over here, but the trigger point is down here. And physical therapists are very good at finding these spots. These are the trigger spots, and they can release these trigger points that can cause these muscles to let go. This is another one. So for example, this one is pain down the leg. The triggers are right here. Pain down the leg, the triggers are right here. This is the trigger point injection. They go into the muscle knot and they inject different kinds of drugs. This is dry needling, where they don't inject anything at all. That works very well. There's a manual techniques that can be used called myofascial release. It's very gentle. It's almost like giving a light massage, but it releases the muscles. There's something called muscle energy technique, which actually utilizes positioning of the body to stretch the muscle out. We talked about muscle relaxants. Caution. Surgery for stabilization of joints, tendons, be very, very careful. Like I showed you, the healing is not as good. You can be left with a weaker joint than you started out with. So it's a good idea to talk to the surgeon and say, like, okay, can you use somebody else's ligament and stick it in me? Cadaver ligaments can be done. Right. So you don't want to use your own ligament. You want to use somebody else's ligament. Or bone graft. Can we use cadaver bone graft? Surgical wounds. This is a little thing. This is for you. Don't worry about it. If you are planning on going for surgery, then this would be the slide to use. How they should be closing up the wounds in patients with EDS. Bed rest. This is the problem. Bed rest, avoid that as much as you can. I know you have flare-ups, but try to avoid it, because then you get into the spiral. If you go in bed rest because of the pain, then the muscles get weaker. Then you have more pain, and then you just go down. So try to, even if you can't get out of bed, just exercise in bed. Raise your arms, raise your legs, move those muscles. We talked about LDN, so I'm going to skip this, but we have used it in EDS patients, and we're getting mixed results. Works in some, doesn't work in some. Opioids, again, this is the weird thing, this is the bizarre thing about EDS. Opioids don't work on EDS patients. You can take a ton of morphine and it doesn't work. For some reason, it's like the numbing medicine. It doesn't work. Lidocaine doesn't work in EDS patients. It's the same thing with here. But the problem over here is that it also causes mast cell activation. So it's not very effective in EDS, but it also causes mast cell activation. If it does work, using a mild dose for a short term is a good idea for acute pain. Cannabis is a good option. It's actually a great option for EDS. The good news, it works better than narcotics in EDS. The bad news is it's not FDA approved, and then there are all kinds of regulations. Vaporizing it, topical, tincture, anything with a low THC content. THC is the one that makes you cognitively high. CBD content, higher CBD content is a good thing. It's a very low addiction potential, actually. And it doesn't affect mast cells. That's the one thing nice about it. If you have gastroparesis, nausea, vomiting, it helps with that. People are on gluten-free diet over here. Just two? No, there must be a bunch of people here, yeah. Yeah, this is, I don't know, I mean, gluten is a protein. We're not sure. It does cause an inflammatory condition in patients. Non-EDS, EDS, both, we see that. It does make a big difference, actually. Try it for 8 weeks. What's the harm? Try it for 8 weeks. If it helps, fine. If it doesn't help, you can go back to service dogs. This is something that's not addressed a lot. Service dogs can be actually amazingly helpful for patients with EDS POTS a lot. They're trained. Each dog is trained to each person's needs. They help with functioning and independence. I've had patients who've actually been able to go through college because they had a service dog. It's a constant companion. Dogs can do a lot more. They're not just there for cuddling with. They actually sense when you're having a POTS, you're feeling POTS, you're going to faint. They can sense these things. They help with security. They can help you out if you're in a crisis. They help with stability. They open and close doors. I've seen dogs that operate elevators. They protect in EDS patients, they actually protect the limb from being injured or touched. So they give you a sense of independence, which then boosts your confidence, which then helps you be more functional. So these two conditions don't cause pain, but they worsen pain. POTS is fainting or almost fainting. There's heart racing, there's fatigue, there are headaches. You feel lightheaded, cold hands and feet, brain fog. And because they have a high heart rate, they're often diagnosed as having a panic disorder or ADD or ADHD, one of those. But it's really not. This is the definition for POTS. Increase of heart rate by 30 beats per minute within 10 minutes of standing, or a heart rate of 120. There's no change in blood pressure. That's the main thing to remember that. The blood pressure doesn't change from lying down to standing up. And then they have symptoms of fainting or almost fainting. The easiest thing to do, is very easy to diagnose this. You do orthostatics. So you do 3 measurements, lying down for 5 minutes. So after you've been lying for 5 minutes, you check the blood pressure and the pulse rate. Have them stand up, do another blood pressure and pulse rate. Keep them standing for 10 minutes, do another blood pressure and pulse rate. And you'll notice that the blood pressure remains the same, but the heart rate goes up. They do a tilt table test, which is the official test they do. For those who have POTS, it's a gruesome test. I don't recommend it at all. Treatment for POTS is really simple. It's straightforward, increase oral salts. So why do patients with EDS have POTS? That's the thing. Remember how I told you that the ligaments, the connective tissue in EDS is elastic, it stretches. So the veins stretch. So when I stand up, blood pools down. When I'm sitting and I stand up, blood pools down to my lower half of the body. My heart pumps it back up into my brain. And all this happens within a split second. In EDS, what happens is there's more blood pooling down there. That's why they have that red discoloration in their feet. There's more blood pooling down, so the heart has to work a lot harder to pump it back up. And so there's a lapse. That lapse causes that syncope, that faint and dizziness, and then their heart rate goes up. Maybe? Sure. Oh, sorry. So compression tights. So the compression tights, again, like I told you, compression tights will prevent the blood from pooling down there. So it can help with that. This is a non-chemical way of treating your POTS. Abdominal binders. Yes?
Where they sell compression tights for young children? Or if anybody does, how we've been trying to find them.
For young children, like how young?
Like 6.
Oh, 6? No, I don't know. So the best thing is to talk to a cardiologist or a neurologist and talk to them about treatment of POTS. But you can do a lot of these things yourself. Or oral salts. Patients, I've had cardiologists recommend anywhere from 2 grams to 12 grams of salt a day. Literally, spoonfuls of salt. Electrolyte water like Gatorade, they've got to drink that. Not just taking the salt, but also drinking fluids. The idea of wearing a compression tight is both helping with the proprioception as well as the POTS part of it. Amy, this will make you really happy.
Thank you.
So Dysautonomia International, they do an amazing job. If you go to their website, you can learn more about POTS than anywhere else. They have recipes. That's what I was telling you was. They have a recipe for high salt diet. And in fact, if you follow the recipe, you really don't even have to take extra salt. Mast cell activation syndrome. Rashes, hives, itchy, fatigue, tiredness, muscle pain, bone pain, racing heartbeat, almost fainting, flushing, especially after a hot shower, and bladder problems, and actually belly problems also. That's the flushing you see after a hot shower. They have temperature instability. It's really hard to get them warm. They have multiple chemical sensitivities, dry eyes, they have difficulty focusing, hair loss, bladder pain. So do you see the common thread between POTS and mast cell and EDS? What are mast cells? This is the nerdy stuff. There are cells in the blood, there are red cells, there are white cells, and then there are mast cells. Mast cells contain a bunch of chemicals. You don't have to worry about all that. This is a really crazy picture. But the one they have is cytokines and histamine. These are the two to worry about. These mast cells, this is what a mast cell actually looks like. That's a red blood cell, and that's a mast cell. See the granules? So these mast cells release histamine, they release cytokines, they release a whole bunch of chemicals. For some reason, in EDS, they get activated. We don't know what the trigger is, but they get activated. They release histamine and cytokines. They're involved in allergy and wound healing and protection against infection. That's the mast cell, that's the cytokine. So the thing with in this case, mast cells the count is normal. In mastocytosis, which is a different condition, the mast cells are increased. And the reason I brought up mastocytosis is because you're not going to find much information on mast cell activation syndrome online. But if you go to the mastocytosis website, you might find some information there. The treatment for mast cell. So the testing for mast cell is really difficult. I don't bother with the testing even, because even if the test comes back normal, I'm still going to treat you for mast cell. So why bother with it? But mast cell testing for mast cell is really hard. The treatment is to start with antihistamine drugs. Remember I told you histamine is released? So you start them on antihistamine drugs. Cold medicines, Benadryl, Zyrtec, all these work fine. But they should be combined with Zantac, 150 milligrams twice a day, combined with a cold medicine round the clock. The only problem with this is that it blocks the histamine only. It doesn't block the cytokines. And the cytokines, these guys, cytokines, you see all these cytokines? These are the ones that cause pain and inflammation. And the drug that works for that is cromolyn. Cromolyn taken orally makes these mast cells stabilize. They stabilize these mast cells. Are you on it? Good. There's something called a low histamine diet. I really don't know much about a low histamine diet, but you can try it. After the gluten-free diet, try the low histamine diet, then the paleo diet, then this diet. You'll eventually wind up drinking water. So the connection, okay, so connecting the threads, headache, brain fog, dizziness, both in POTS and mast cell. Blurry vision in both of them. Racing heart, both of them. Belly pain is both of them. Weak tremulousness or weakness or trembling is in both of them. Dark discoloration of feet is in both of them. So what is it? Is it POTS, is it mast cell, or is it both of them? Or is it EDS? So there's a common thread in all this, and we haven't been able to put our finger on it. What's the common thread in all these conditions? This is an NC10 rule. I call it the NC10 rule. This is my invention. So you use one therapy, okay, and a drug, number one, okay, and you get 10% relief from it. You take another one. You do another therapy. You do physical therapy. You go to Julie and she does something to you, and you get another 10% relief. But although Julie will give you 50% relief. But anyway, you get 10% relief from that. So you've got 20% so far. You put a third one, you get 30%. You put a fourth one, you got 40%. And eventually you put a fifth one and you've got 50% relief. So using 5 different modalities or a bunch of different modalities can get you the kind of functioning that you need. Don't expect any one of these to make the big difference. Say, for example, you take salt, you drink more electrolyte fluid, you put your Spanx on, you correct your POTS, the mast cell, you start taking those cromolyn, the antihistamines, you start correcting these one at a time, expecting all of these to work slowly. Tethered cord syndrome, again, this is tethered cord. For those of you who don't know tethered cord, the spinal cord normally hangs freely from the spine. As it comes down the brain, it hangs freely down there. So that as we grow taller, it grows with us. As we move, it moves with us. In tethered cord syndrome, the end of the spinal cord is actually tethered down to the lower back, to the tailbone, literally. It's really taut. It's really tight there. The symptoms are back pain, leg pain, decreased leg in children and young adults. You see all kinds of pain, muscle dysfunction, spasticity, increased reflexes in the young adults. But the big one is neurogenic bladder and frequent urinary tract infections. These patients present with these symptoms a lot. So it's really a lot of pain in the back and down the legs with bladder symptoms. They pee a lot. Every time they go, they have to rush to it. It's always an urgent matter. When they finish peeing, they still feel like there's some left in there. And there's a test for it called the urodynamic study. They can do that. They present with incontinence and constipation. They'll have scoliosis. It's progressive scoliosis. So it can also happen after back surgery, by the way. That's the picture of a tethered cord. So you see, it's the cord actually ends at L1 normally. In tethered cord, it ends at L3 because it's being pulled down here. That's the cord which is tethered down there. It is a high prevalence of tethered cord in EDS. You can have, in fact, some people have a dark patch on the back. You can see that. That's what it looks like. That's a dark patch you can see. You can see a dimple there. There's another dimple there. That's a dimple. That's not what you think. It's a dimple. Just being clear. MRI is not a useful test for tethered cord syndrome. So if anyone tells you that your MRI is normal, therefore you don't have tethered cord syndrome, you've got to stop seeing him. Okay? Diagnosis is based on clinical history and examination. A urodynamic study is a helpful test. If that is positive, then it's a helpful test to figure that out. But it's mostly a clinical diagnosis. The spinal cord is really like a guitar string between the two. In fact, this is a picture. You can see that that's the tethered cord. So this is a spine opened up. And you can see the cord. And you can see these red lines. Those are the blood vessels. A cord, normally, that's a phylum actually is called, doesn't have blood vessels. In a tethered cord syndrome, they get blood vessels over there. It's really simple. They snip this, and they take out a piece of it. So connecting the dots, you can see fatigue, diffuse pain, headaches, joint pain in all of these conditions. GI issues. We didn't even talk about gastroparesis, which happens in mast cell activation syndrome. Feeling anxious, that can happen from POTS and mast cell. And they get misdiagnosed as having ADD or panic disorder, anxiety, and then you go see the psychiatrist who tells you all kinds of stuff. We're finishing up. Fatigue. Plenty reasons of fatigue. EDS, POTS, mast cells, and then on top of that, the drugs, the Neurantins, the Lyricas, they all make you fatigued. And then, of course, the pain is tiring. Treat the cause. Whatever the cause is, treat it. We've started looking at using what is called a mitochondrial supplement. Some people think that it might be secondary mitochondrial dysfunction. And it's worth trying one of these mitochondrial supplements to see if it makes a difference. The end.